Welcome to Pause for the Truth, where you can sit back, relax, and hear an honest dialogue about health, wealth, legal, and social issues. The hosts are Dr. Rogers Kane, family practice physician, and Jocelyn Turner, health education consultant, with co hosts from the Northeast Florida Medical Society and its foundation. Stay tuned for the truth about matters affecting you and your family. We're here to tell you what's really going on and why.
Good evening. I hope everyone is doing well. It was a great day in Northeast Florida. The weather was pretty good. Um, a little bit of rain, but no big deal. Um, we are waiting on Miss Turner to show. The star of the show. She should be here any minute. um, but the true star tonight is Dr. John Kelly Washira. Dr. John Kelly Washira is a pulmonologist here in Jacksonville, and the pulmonologist is the lung doctor for those that are think that Dr. Kane trying to use a big word on them. I'm not trying to be fancy, anything of that nature. But he's a pulmonologist. That means he takes care of various lung disease, which he will get into it quite a bit. I'm going to let Dr. Washira at least tell you about his practice and where it's at while we waiting on Miss Turner as well. But Dr. Washira, how you doing this evening?
I am doing excellent. Thank you, Dr. Kane.
Very good. Tell us a little bit about yourself for our audience that don't know you.
Yes, sir. I think before I do that, I just want to, again, just thank you and your team for having me, number one, and then more importantly, for the work that you're doing. I think it's needed and it's celebrated. So we celebrate you and your team for being a voice and having this platform. And again, thanks for having me. So yeah, like you said, I am a lung doctor, and I'm also an ICU doctor as well. Those kind of tend to go hand in hand. So I have the great privilege of taking care of both outpatient and inpatient patients. And so I work at Baptist Hospital, predominantly at our downtown campus. When I'm rounding in the hospital, in the ICU, or in the wards. And then for my outpatient practice, I work for a private practice by the name of RCCSM, which stands for Respiratory Critical Care Sleep Medicine. And so that's what I do, about 50-50 clinic and then 50% hospital privileges.
And so Dr. Washira is one of those people that survived COVID. And I mean, he was in the face of COVID victims.
Yes,
okay,
sir.
More so than I was. I mean, I did him on outpatient, but he was out there saving lives right and left during those critical moments when we really need a respiratory specialist to help treat COVID. He didn't quit on us. So I commend him for that, because he put himself in danger multiple times. If you guys recall what was going on with COVID and the lengthy process that it took for us to be taken care of in our community. So he's one of the heroes here. So, not me, Miss Turner and Mr. Jackson and Dr. Washira may be all the heroes, because they was out there on the front line talking the yin and the yang. Dr. Washira, this is Jocelyn Turner. She's my co-host, the more articulate person in the group. She has a health education background, and she's quick to tell you, I don't know anything, but y'all gonna teach me.
And as you were talking, hello, Dr. Washira. As you were talking, actually, to be honest and transparent, as we talked about the topic of lung health, and I'm like, So my dad had lung cancer. Unfortunately, that's what he died of. And but he was a smoker. And when I started my career in public health, ex-smoker, I was leading up to that. When I started my career in public health, Dr. Washira, my dad was a smoker at that time. I don't remember how many cigarettes he smoked a day,
Yeah.
but as a young health educator, I started pumping information to him as I got from the health department, and
Yeah.
he quit cold turkey.
Good for him.
Unfortunately,
Yeah.
unfortunately, 30 years later, he was
Yeah.
diagnosed with lung cancer. He survived the first diagnosis, but the second one, coupled with his other diseases,
Yeah.
he didn't survive it. But he was, he was 83,
Yeah.
right? So, but anyway, we still didn't want him to leave no matter what.
Right.
But
Right.
fast forward, I had a friend, and I won't say his name, but during COVID-19, he was diagnosed with same stage 4 lung cancer and brain cancer. And oh
Mm,
my God, he's doing amazing
yeah.
today.
Yeah.
He's a younger man,
Hmm.
but still, I could not. I was so haunted for him thinking of my dad
Yeah.
and his diagnosis. But Dr. Ashira, outside of that, why is it? And you may have talked about that in your introduction. I apologize to you and our audience for being late, but there are so many people nowadays, younger people, and just people across the life spectrum who have asthma. And, and I know there are environmental factors,
Yeah.
but what are some reasons that it seems to be so prevalent in African Americans and in families?
Yeah. So yeah. So great question. And I'm sorry about your dad. And it's funny because one of the things that I was planning on talking about it is lung cancer and some of the screening programs that we have so that we can sort of mitigate cases like your dad and the friend that you mentioned, because now we actually have evidence to show that screening is vital and it saves lives. And so, when I trained, on the back end of my training, this kind of sort of national program, national lung cancer screening program was initiated because prior to that, we didn't have any mechanism or any protocols of screening for lung cancer, and yet it is the number one cause of cancer related death in the United States.
Wow.
So there's been this huge initiative, from a federal standpoint, recognizing that this is a need and coming up with a plan. So, and hopefully, we can save people in the future, and we are saving people in the future. Now, to your question, very good question. Asthma has evolved over the last several years in terms of diagnosis and in terms of management. Now, your point is very well taken in terms of uh, some of the environmental triggers. The unfortunate thing is, and this should not be breaking news, is when it comes to black racism or prejudice or those kind of issues, uh, they have been, whether it's an interpersonal form or from a structural or systemic form, it's been embedded in our society for generations. And the unfortunate thing is it has profoundly and negatively impacted African American social determinants of health.
Mhm.
And that includes where we live, when because it affects our economy, our stability, and so we tend to live in kind of in the low income neighborhoods. The unfortunate thing is, because of that, the rates of pollution and exposures are much higher compared to the suburbs or areas that are better off. And we know for a fact that those are some of the triggers that exacerbate and cause asthma. So it becomes this complex interplay of so many factors. Whether it's the socioeconomic status, whether it's our neighborhoods, whether it's what's within our homes in terms of the air quality, and subsequently, we know that there's a genetic predisposition as well. To your point, we know that that's also another element that just kind of adds to the complexity of the diagnosis as well as the management. But I think it's a myriad of all these reasons that has made asthma what it is. The good thing about it is there's hope. There's a lot that we can do different. And advocating is one thing, but even from a physician level, management, because all we had before was inhalers, um, and inhalers are good, and they have their place, but what we found is for some of these severe asthmatics, uh, they need something more than inhalers, and the newest kind of kid on the block is shots that we call biologics, and these are monoclonal antibodies that we use to treat specific patients that have uh, sort of different manifestation of asthma, because there's actually different forms of asthma. There's what we call eosinophilic asthma, which is basically when you have these elevated eosinophils that can actually go into your lungs and rather than helping you, actually start harming you. So, and there's a way to check the levels of these eosinophils, and better still, ways to target them to bring them down. And then there is what we call allergic asthma, where you can actually do a blood test and look at some of the allergy markers, and again, you can target these allergy cells to sort of decrease the symptoms. And then the last group is called neutrophilic asthma, which is frankly the worst you can have, because it's very difficult to treat. It doesn't really respond to the traditional methods, whether that's inhalers or steroids or the biologics that I just mentioned.
That's
Yes.
a tough one too, but
Yeah.
that's the one I have to send off to you guys to treat the eosinophilic and the allergic asthma.
Yeah.
They're kind of on the same plane to a degree.
Yep. Mm-hmm. Yep. Yeah. So yeah, there's a lot of kind of,
Overlap.
yeah, they share a lot of similarities, and you're right. There's a lot of most people that have, there's a lot of combination of patients that have both eosinophilic and allergic asthma. So you check their IgE, and their IgE is elevated, and you check their peripheral eosinophilia, and sure enough, their eosinophil count is elevated. And it sometimes it's more of a gestalt on which one to target. If you talk to most experts, they think that targeting eosinophils has a bigger bang for your buck than going after the IgE. So like if you came to me and you had a syndrome that had both phenotype, both of them being elevated, literature is suggesting that going after the IgE will actually even help you going after the eosinophils will actually help you bring down your IgE levels.
Yeah, and IgE, for those that are looking, is an immunoglobulin
antibody. Yeah,
antibodies.
Yeah.
That your body responds. Well, that's a response your body builds toward things that that initiate an asthma attack. It kind of like things that you're allergic to. It builds up the IgE levels.
Yeah.
In an effort to deal with the allergy, but what it winds up doing as well is causing such an inflammatory response.
Yeah.
That is difficult to breathe.
Right.
I suffer from asthma, so I understand.
Yeah.
Okay.
Well, shoot, I was thinking as you were talking, Dr. Washir, I was thinking I had a allergy testing done recently, and oh my goodness, look like I'm allergic to the world. But
oh, there you go. Right.
Primarily, one of the things that started happening, but is I started noticing I was wheezing.
Yeah. Yeah.
And I have family members who have asthma.
Yeah.
And so I'm like, oh my goodness, is it happening to me? But I did the allergy shots, and now I'm doing the allergy drops.
Gotcha.
And they said it may take a couple of years before it happens. But why do you, and by the way, Dr. Ashir, I hear a lot of people wheezing.
Yeah.
And I wonder, and I wonder, I was like, oh my goodness, I wonder if they're doing anything about it, right? And are they going to a doctor like yourself, or is somebody taking care of? And I didn't know there were so many degrees of asthma, as you just explained.
Mm-hmm. Yeah. So again, very good question. So word of caution, not everybody that wheezes has asthma.
Mm-hmm.
Now wheezing is bad 100%, but the work is in teasing out why you're wheezing. And I'll give you some examples. So if you have fluid in your lung, you're going to wheeze. Okay. If you have inflammation in your lungs, you're going to wheeze. And sometimes even if you have an infection in your lung, you could wheeze. So part of the work when somebody comes to me and tells me they're wheezing is I can't just willy-nilly just assume that they got asthma. I got to do the work, which is number one, talking to the patient, which is the history element of it. And then listening to them, listening to their lungs and seeing what, are they wheezing everywhere, or is it a particular part of their lungs that's wheezing? And then we got to do the objective testing, which is the breathing test, to see what their lung function looks like. And then you couple that with the blood work that we just talked about, looking at some of these inflammatory markers, like the eosinophils and these antibodies that we were talking about. But you're right. There's a lot of folks that wheeze for multiple reasons. We got to make sure they don't have congestive heart failure, because again, if they do have that and they're holding on to fluid or hiding fluid in their lungs, they're going to act like asthma. Some individuals have really bad acid reflux. And believe it or not, when the acid refluxes into the lungs, guess what? It's going to wheeze, And so really, if you just get ahead of the acid reflux, then the wheezing goes away. So part of it is kind of putting on that detective cap on and doing the due diligence to kind of look at each patient very differently and kind of go through that algorithm of trying to figure out what's really driving that wheezing. And then once you figure it out, attacking it. And frankly, there are a lot of times where we miss it. If I'm going to be honest with you, there are times where, I feel pretty strongly that it's asthma, and I start the patient appropriately and they're still wheezing. And I got to go back and tell myself, you know what, Kelly, you missed this. Go back to the drawing board and think of something else, because clearly it's not the asthma, because you treated the patient appropriately, but they're still, exhibiting the symptoms.
That's it. What he's doing is he shows me why I like him so much, and that is because he recognizes that he's human just like the rest of us.
100%.
So when he may come in with a diagnosis and it doesn't match out, then you go back to the drawing board.
Yes, sir.
It reminds me of one thing that first thing I learned in residency in terms of asthma and stuff. Not all asthma wheezes.
Yes, sir.
And not all that wheezes is asthma.
Is asthma. There you go.
Yeah.
Well said. Yes, sir. Yes,
but
sir.
One of the things, and we kind of talked about it at the onset, and I do want to get back to it. Again, you kind of talked about it in regards to the social determinants of health, but I'm sure a lot of people who are listening to us really want to know, why are African Americans disproportionately affected by asthma and lung cancer?
Yeah. So I think we can tackle each at a time. So like we said, when it comes to asthma, there's just so many factors that lead to asthma. One is the air that we're breathing in. The other one is some of the allergens or some of the irritants or some of the exposures. And like I said, some of these social determinants of health that are a challenge or a barrier to us, whether that's education or economic stability or our neighborhoods or access to care or insurance or being able to afford. It's one thing for me to make insurance accessible, but it's another for me to make it affordable. And all these determinants
and quality of housing. If you're a renter and you don't know the
100% quality of our housing. If most of our people are in the kind of low economic neighborhoods, low income neighborhoods, that's kind of where the concentration of pollution is, and some of those are older homes. They're not very well taken care of in terms of having triggers like radon and asbestosis and dust mites. All these things, all of them contribute to asthma. And the unfortunate thing is like you said, there's a huge disparity between African Americans and other races. And so because of that, the prevalence of asthma is much higher, because these barriers affect us in a much higher capacity than other ethnic groups. And so as such, we're kind of behind sort of mitigating upon these challenges. Now, when it comes to lung cancer, it gets even more complex because, again, lung cancer, most of it, not all of it, is because of smoking, right? So again, there's that myth of all cancers is from smoking, and that's not true. But most of it is from smoking. and if you look at smoking, the the big tobacco companies literally target Black communities as far as advertising for cigarette smoking. There is a huge campaign specifically when it comes to menthol cigarettes, targeting our younger,
Yep.
basically our children, much more than they target any other ethnic groups. And really, they disguise it in terms of campaigns and outreach programs. They'll sponsor, like,
It's sexy. It's
right.
pretty.
They make it exactly right. And what they don't tell you is menthol cigarettes are easier to start, but they're harder to stop. So once they get you hooked, you're
They got
addicted. They got you,
got
right? And again, this is why we need to leverage and put so much pressure on our elected officials to protect our kids, to protect our neighborhoods. We just came off an election year where everybody is promising us all these good things that they're going to do for us when we vote for them, and then the minute we get them into Washington, we can't see them, or we can't see their promises. And so we have to hold these leaders, elected officials, from a state level to a federal level to the highest rank in office, that being the president, to really do what they promise us to do. And that's getting rid or helping overcome some of these barriers that have created these disparities, whether that's from an asthma standpoint, how can we help our communities, and whether that's from a lung cancer standpoint in terms of access to the right healthcare, making it affordable, and treating our patients the way they deserve to be treated.
Dr. Bashir, you really illustrated exactly what this program is about.
Yeah.
We're trying to bring to bear the placing the responsibility of some of the things that occur in our community on our elected officials.
Yeah.
Some of it is on us because
100%,
of personal habits.
Yep.
If you're not from this area, neither am I, but I've been here a lot longer than you. And so I think Ms. Turner can remember when we had those smelly days in Jacksonville where you had all the
factories.
What was it? That was
those factories that
those
were
factories, wood pulp places. I mean, you go outside on your car and there's ashes on your car.
Oh, wow.
On the Jacksonville north side.
Yeah.
It was horrendous. And the first thing I recognized when I got to Jacksonville as a resident back in 1985 was the amount of lung cancer and asthma that we were seeing. It was ridiculous.
Yeah.
And so not until the elected officials, including our state officials, went and bear down on that industry that's responsible for all that pollution that we had in the Black neighborhood.
Yeah, right.
It wasn't in the neighborhood I currently live in.
Right.
But it was in the neighborhood that I used to live in.
Right.
So
no, it's a well-documented fact that some of these industries strategically will build around neighborhoods that are mostly from minority occupants, and again, here we are now exposing our people to these toxins that are not good for your body, and that have carcinogens, have the ability to give you cancer down the road. And we wonder why the prevalence of these illnesses is disproportionate. There's a clear link, Now, the fact that we know about it, we got to hold these people responsible, right?
Yes.
Because, that's where advocacy comes in. And again, holding our elected officials responsible to advocate for us. And also, like you said, there's a part for us to play. We got to advocate for ourselves and basically hold these individuals and these companies responsible for some of the things that they've done.
So what role does early screening and diagnosis play in preventing severe lung conditions? And is it underutilized in the Black community?
Yeah. So again, another great question. So we've come a mighty long way in lung cancer treatment, but even more so in diagnosis. And so, and with lung cancer, like you had mentioned earlier with your dad's case and the friend that you highlighted, it's all about the stage that you catch it in, right? So there's stage 1 and 2, which are curable, and then there's stage 3 and 4 that are not curable. So essentially, you're just kind of trying to get ahead of the disease and buy the patient as much as quality time as much as you can, right? So obviously, in that scenario, the earlier you catch the disease, the better the patient does in terms of prognosis, and frankly, sometimes in terms of curable state, in terms of literally just they no longer have cancer because you've taken it all out. So because of that, this initiative of screening, lung cancer screening, because lung cancer in and of itself is, like I said before, the highest cause of lung cancer related deaths. It's lung cancer compared to all cancers that you're aware of, whether that's gastrointestinal or breast cancer, which gets a lot of press for the right reasons. But even breast cancer does not come anywhere close to what lung cancer does in terms of mortality and morbidity. And again, some of that is it gets bad press because most people tend to think it's related to smoking, so you did something for it. But the reality is you can have lung cancer without smoking, especially women. So yeah, so this initiative is evidence based. There is a criteria that you have to qualify. One of them is age. You have to be between age 55 to age 77. That's one criteria. The other criteria is you have had your smoking history has to be greater than 20 plus years. And you could be a current smoker. So being a current smoker does not exempt you. Or if you're no longer smoking, you have to be within 15 years since you quit. So if you meet all these criteria, and I think your dad would have met this criteria, by the way, from everything that you told me, then you qualify for an annual scan of your lungs. And it's a different kind of a scan of your lungs. It's a low dose scan of your lungs. So it doesn't give you the same radiation you would get. Like if you went to the ER for shortness of breath and I had to scan your lungs, you get more radiation from that scan than you do from a screening a scan for lung cancer. So this has done wonders in terms of catching smaller nodules or masses that would, if left untreated or unmonitored, develop into lung cancer. So certainly that has been a good thing. Now, your point is very well taken in terms of how has that affected us? Now, again, one of the social determinants of health, like we said, is access to healthcare and affordability, right? So I cannot tell you how many times in the hospital I take care of our people that are young and healthy, but because of lack of resources, never really had the right amount of screening or the right amount of education, because that's another issue there is educating our people in terms of who's at risk and who's not, and then subsequently, guiding them on what, how to proceed. But I take care of a lot of folks, in the hospital that I don't have the ability to follow as an outpatient because they don't have insurance. So that gets real dicey in terms of how do you, this is somebody that needs screening or surveillance or, management, but then these social determinants are actually affecting my ability to follow him in private practice.
So are there any symptoms? I'm sorry. Are there any symptoms of lung disease that go unnoticed or ignored in African Americans?
Yeah. So great question. Yes. So any sort of subtle cough that is not going away, specifically a non-productive cough, it's very worrisome. And again, and that's the thing, is a lot of times we've minimized some of these symptoms because, it doesn't hurt, or, you just kind of learn to live with it. But any sort of cough that is not going away, greater than 6 months is very concerning. There are other symptoms that we call constitutional symptoms, and those are like unintentional weight loss. You're just eating regular food, but you're losing weight without really wanting to lose weight. That's very, very worrisome. low grade fevers. It doesn't look like an infection. You don't really have any obvious signs of infection, but you're kind of
Mhm.
running kind of a little bit of a low grade fever, and you really don't have the energy that you had. Kind of you're a little bit lethargic. Those are all very kind of telling symptoms, specifically when they're chronic. When they're not going, it's all of us experience those symptoms, once in a while, but we get better, right? But if those symptoms are coming and they're not going away and they're lingering for weeks to months, those are very concerning symptoms.
I think we want to make sure that people understand, and Dr. Bashiri did a great job at it, but I'm trying to make sure that those people understand that there's screening tests, low dose CT scan, CAT scan, as some people
Yeah.
call it, a
Mm-hmm.
low dose CAT scan, as he said, low radiation, blah, 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 that can help us detect it earlier
Right.
than if you just do a plain chest x-ray.
Right. Right.
Chest x-ray, plain chest x-ray for years was the way to go.
Right.
But when we recognize that low dose CT scan, now I tell patients, and I'm probably not telling the truth, but I tell them, I say, look, we can probably detect this 5 years earlier with a low dose CT scan than you can with a chest x-ray.
I think you're right.
And so I try to make sure they understand that. And so those guys that smoked and met the criteria that you just said in terms of being within 15 years of having stopped smoking and or the amount of smoking they were doing per year,
Yeah.
it fits great. Only thing that I wind up doing, run into some controversy sometimes, is those passive smokers.
Yeah.
Who their spouses smoke like a smokestack,
Yeah.
3,
Yeah.
4 packs of cigarettes a day, and
Yeah.
you're in the house with them. So now you're looking at the asthma and the COPD, which you're going to probably talk about, and the lung cancer, the risk of lung cancer. None of that is minimized just because you didn't actually stick the cigarette in your mouth.
Yeah.
But you reaping some of the bad effects that you should have been designated only to the smoker.
Yeah.
But it doesn't.
No, wait a
Very,
minute,
very good
Dr.
point.
Bashir. I just got to insert this. What grinds my gears, as my niece would say, is when I'm seeing adults in the car with the windows up, smoking, and there's children in there.
Yeah.
Oh, that just burns me up.
Yeah.
I'm sorry, I just had to interject.
No, it's funny you say that, because I was driving the other day and I happened to look to my side, and there was, I got 2 little girls. I got an 8 and 10-year-old. So, and this little child, looked like my daughter sitting in the back seat there, and they looked like a grandma, and she was out there just smoking. And in my head as a lung doc, I'm like, oh my goodness, I could just see everything just happening. I'm sure this had been happening for a long time, and this, young boy is being exposed to this, this smoke that unfortunately will have a negative impact on his health. So it's the good thing about smoking is, again, we've come a mighty long way in terms of helping these patients. And one of the challenges that I challenge myself anytime that I'm taking care of my smoking patients is, I do think the approach and the tone matters. Most smokers will tell you, I hate doing it, I want to stop, I just don't know how. They recognize what they're doing to their body. They recognize that it's not good for them, but they're just so addicted. They feel helpless. And I feel for them as a physician. And frankly, my tone is very, very different from a lot of my peers. You can just see anytime you ask a smoker, are you still smoking? Just by their face, there's embarrassment.
Yeah.
They're, just the whole demeanor just shifts. And so really, I just tell them, listen, I recognize this is a difficult habit. I get it. I got my own stuff that I'm dealing with. It might not be smoking, but I got my own stuff too. So the key is, how can I help you, get to the other side of this thing? Because right now you're self-sabotaging yourself, and so there's better ways of dealing with whatever stress that's making you smoke, whatever trigger that is causing you to smoke. How can we shift that into maybe something that is not, hurting you? And when the tone is you're not accusing them, you're not judging them, you're recognizing this is a human issue, and recognizing that smoking and that's the challenge too. We need to look at smoking as a medical condition, not as a habit. Because then the perspective shifts, right? It's like, okay, the same way I'm vigorous about lung cancer, about asthma, about congestive heart failure, I need to be about it when it comes to smoking, because just because they stopped today doesn't mean that they're not going to relapse 3 months from now. Exactly. So kind of continuing that conversation in a very in a tone that is they can receive you. We have more effect in helping them get on the other side, and then offering them all the resources that we have, because we got a lot of resources that we did not have, whether that's the patches, or Chantix, which is a pill, or Wellbutrin. All of them have very good evidence to say that they help decrease the urge. And there's some things that they can get over the counter as well. There's some free resources when it comes to the telephone quit lines, that they can talk to a counselor that is trained to walk them through this journey. So offering them all these resources has been quite impactful and successful.
So we're going to take a break, Dr. Washira. Don't go anywhere, but we're going to have a midway minute, as we're calling it. It gives us an opportunity to see what our behind the scenes guy, Tyrone, has done regarding tonight's topic. So don't go anywhere. We'll be right back with our discussion with Dr. Washira.
Hey everyone, welcome to Pause for the Truth. Welcome to our Midway Minute, December 17th, 2024. Today I want to talk about something really important: African American lung health. Did you know that African Americans are more likely to have asthma, lung cancer, and other respiratory diseases than any other group? Yeah, it's true, and it's something we need to talk about. Let's start with asthma. African American children are twice as likely to be hospitalized for asthma compared to white children, and the rate of death from asthma is 3 times higher in African Americans. This is heartbreaking, and we need to take action. Now let's talk about lung cancer. Despite smoking at similar or lower rates compared to white Americans, African Americans are more likely to be diagnosed with and die from lung cancer. It's not all about lifestyle choices. There are deeper, systemic issues at play. But there is hope. There are incredible African American doctors and researchers making a huge impact in the field of lung health. Dr. Andrea McKee, a pioneer in lung cancer screening, is working hard to ensure early detection and better outcomes. Dr. Leroy Graham, a leading asthma specialist, is dedicated to improving asthma care and education in underserved communities. And Dr. Keith C. Ferdinand is a champion for addressing health disparities and advocating for better healthcare access. We have the power to change these statistics. By raising awareness, advocating for better healthcare, and supporting the incredible work of these doctors, we can improve lung health in our communities. So let's take a deep breath and work together for a healthier future. Thanks for watching, and don't forget to like, subscribe, and share this video to spread the word. Stay healthy, everyone.
Thank you, Tyrone, for that midway minute. Dr. Washira, I have to mention vaping, because it seems like it is now the sexy or cool thing to do rather than cigarettes. Tell me about it, and does it have the same or similar effects on one's health as cigarette smoking?
So it kind of depends on who you ask. There's a lot of controversy when it comes to vaping. So again, vaping. So the difference between vaping and smoking, one is, so you're heating a liquid, right? So you're not burning tobacco; you're heating it. You're heating a liquid. And so you're bypassing sort of all the carcinogens that you would burn with a cigarette, basically. So some people will argue, well, so it's a much safer use or consumption of the product, and that is true, right? The problem is it comes with its own things, right? So that liquid that we're talking about that you're heating has other components, and some of those components include humectants like propylene glycol or ethylene glycol, which is a preservative and can really hurt your lungs, and vitamin E, and that's kind of where we ran into this issue a few years ago when we lost a lot of young folks from something called ARDS, which is adult respiratory distress syndrome. And essentially what it is these e-cigarettes and vapes can cause an inflammatory condition within your lungs. It's called E-valley. E-cigarettes and vaping associated lung injury. It's a terrible lung condition that causes this inflammatory cascade in your lungs and affects your ability to oxygenate, and you need to go on a ventilator. Then the unfortunate thing is it's relatively new. So as lung docs, we don't really know how to manage it. We don't really have the greatest resources to leverage treatment. So it was more of a kind of a guess on how to treat these patients. And so we lost patients. So to me, there's a way you can leverage it to help somebody that is stuck, like an older patient. The problem is what has happened, just like with tobacco and the menthol, is they're marketing this to our kids, and that's kind of where the problem is if you look at the statistics, vaping is rampant in our middle school and high school and colleges, because that's the target, that's a market, right? And what they've done is they've created so many flavors of this liquid that we're talking about that you can inhale, whether it's candy, in any form of like fruit or candy, or it can come in an e-cigarette form. And so that's kind of what has made it such an attractive thing. I get really concerned as a lung doc because of who is consuming it. These are young folks that their lungs are still developing, that they're not at their peak yet. And so I do think there's more to come from a vaping standpoint, because right now it is just rampant in our high schools and middle school and colleges. And I think we're yet to see the impact of that. I think obviously as a lung doc, the right thing is to stop either. None of them are good for you. But like I said, depending on who you ask, one of them might say, maybe this is a lesser of two evils because of what you're bypassing. But the reality of it is it comes with its own issues that you got to be cognizant of.
Now, for me, what I wonder, and you can help me clarify, Dr. Rashira, those guys that are vaping, when they add that vitamin E or vitamin D, whichever one it is, they're oil soluble, fat soluble. Your lung is not oil or fat soluble.
Yeah.
It's water soluble.
Right.
So now you get these oily substances deposited in your lung.
Right.
Which will destroy it in an instant.
Right.
My wife's mother did hair for a living. She was a beautician.
Yeah.
Back in the day when they would take the I'm gonna say Vaseline, but it's Roy Crown stuff.
Yeah.
And fry the hair, and she would inhale it, not intentionally, but she was doing hair. That's how they did hair back then.
Yeah.
And when she got a certain age, she had all these ribs and big lung vacuums, in her lung. And I threw it to her pulmonologist at the time, non-African American, and he didn't think much of it. But I'm going like, and this was probably 20 years ago.
Yeah.
Like, but it doesn't make any sense for all of that fat, the oil-soluble substances in a lung that's basically water soluble.
Yeah, right.
Between oil and water, they don't mix.
It don't mix. No, your point is very well taken. And again, there is an acute reaction, and those are the people that get sick real quick after exposure, and those are the people that they're fighting for their lives in the ICUs on a ventilator with ARDS. And then to your point, there is this kind of chronic subset of patients that, frankly, we're yet to see how the future outcomes of chronic vaping.
Right.
And your point is very well taken. Some people, there's something called lipoid pneumonia. Yes. And a lot of people are not aware of that. And essentially, one of the major causes of lipoid pneumonia is when people use Vaseline in their nostril.
Wow.
You shouldn't do that, because, there's a place for it, but traditionally, like our grandmas, they would use the Vaseline and they would go to bed, and so they're inhaling that Vaseline when they go to bed and it gets into their lungs and they actually have what's called lipoid pneumonia. And it's a terrible form of pneumonia. And essentially it's what you just described. It's Vaseline or fat that is not water soluble, that goes into your lungs and causes all these, infiltrates or consolidations in your lungs that affect your breathing. So, and you could make a case that I think we will see that down the road, with these kids that have been vaping for, since middle school or high school, which is really what's happening.
Well, Dr. Kane brought up something that, I'm sorry, Dr. Kane, I got to piggyback on what you said, because every time I go into a hair or nail salon, particularly the nail salon, the fragrances that are in there from the products that they use, I wear my mask, but not that that's 100% foolproof. But I often wonder, I look at the people who are working in there and the constant exposure to those products. Do you recommend people that if you work in situations like that, which I call close quarters, that they just make a habit of wearing a mask, not just the worker, but the clients as well?
So there is something, believe it or not, that we talked about asthma and we talked about the different manifestations or phenotypes, the eosinophilic and the allergic and the neutrophilic. There is another one that we didn't talk about, which is occupational asthma. And that is what you're basically describing. There are some jobs that literally will predispose you to asthma. And you're 100% correct. One of them is a hair salon, because of the chemicals that you are using that sometimes will just not agree with your lungs, right? And I actually have a subset of patients that's really what they do for a living. And you have to have that really difficult conversation of, you got a really big decision to make. I recognize this is how you earn a living. So if there's no other option in terms of getting a different job or learning a new trade, then how can we protect you, when you are being exposed constantly to these triggers, right? And you're right. One aspect is a simple mask, and your point is well taken. It's not 100%, but believe it or not, it filters most of those larger particles, and there is benefit there. So to me, if I was in a situation, in an occupation where I knew that over time it could hurt my lungs, the least I would do is just wear a mask. I mean, it is offering me some level of benefit, and so you can never go wrong. It's not 100%, I'll give you that, but it's better than nothing.
You mentioned something earlier. When I grew up, of course, me being older than all of you guys, one thing that when we had asthma, that my mom would do and grandmother would do, mentholating. They would take it and stick it up your nose.
Yep.
And that is basically Vaseline with menthol. It felt so much, you breathe better. But little did I realize, until I was this year's old, did I realize what damage it might have been causing my lungs.
That's great. So I have to ask you, Dr. Rashir, are there any lifestyle factors, diet, exercise, or whatever, that can reduce the risk of lung diseases?
So lifestyle modifications are obviously one area that we highly focus on, specifically in asthmatics and COPDers, because the more you're stretching and exercising that lung, the better function you're getting out of it. So there are benefits to staying as active as you can, eating the right foods, because that will keep the weight down as well. Because the other element of it is weight, because the more weight we hold on to, the more it affects our breathing. So there's kind of catch-22 where not only does it have physiological benefits in terms of blood flow, in terms of oxygenation, in terms of working that lung and stretching that lung from a function standpoint, but there's also the other benefits of the cardiovascular benefits, keeping that weight down, which ultimately will improve your breathing once you stay within the correct BMI.
Wow, it's just, and Dr. Rashir, you And I apologize. Once I got on, I just started talking to you and forgot you had prepared some slides that you wanted to show. Do you still want to show those, or shall we
No,
go
no.
on?
I honestly, I like this freestyle. This work probably,
Dr. Kane
you know.
didn't warn you that I can go once I get started.
Well, he warned me. I'll tell you that. So.
Oh, wait a minute. Wait a minute. Wait a
It
minute.
was not derogatory. Shut up. It was
No.
not derogatory.
But you know what? But honestly, I think I like this better because the way I had planned on doing it was going to be quite formal,
Yeah.
and it's a little bit dry, and freestyling it or ad-libbing like this, you might catch me off guard, and I have to think about a response. But you're putting me on the hot seat, and I'm okay with that. So no, I actually like this better. You can keep the presentation. We can always talk about it at a different time. Sounds like Dr. Kane wants me to come back at some other point. I'll be happy to.
For sure.
I'll be
Yeah,
happy
because
to go over it at that point.
yeah, because I do have a question. Dr. Kane talked about, you were pretty busy during the COVID-19 epidemic. Are you seeing any long COVID situations in your patients, and what do those look like?
Yeah. Oh man, I tell you, you've had excellent questions all session long. Yeah, the answer is yes. That was a very, very trying time.
Yes, indeed.
And the unfortunate thing is, we lost more people than survived, right?
Mm-hmm.
I could think of 2 patients right now that I still see that give me so much joy every time I see them, because in the beginning, with the Delta variant, I don't know if you remember that one. That was a bad one.
Yes.
That was the worst one.
Yeah.
I want to say probably 99% of everybody that I intubated died.
Wow.
And I have 2 patients that survived, and I still see them to this very day. And I don't know why they survived, because that gut-wrenching moment where you have to make a decision that this is the intervention that I have left to help you, but at the same time, I know that if I do it, your chances of making through it is close to, it's not 0, but it's close to that. Is a gut-wrenching decision, specifically when somebody's younger than me, and I'm not that old. I'm getting older, but I'm not that old. It's a tough place to be. It's a tough decision to make, but we had to make those decisions. Now, I still see those 2 patients that were able to make it, that had that Delta variant that was extremely powerful, and they have done remarkably well in terms of being able to be weaned off oxygen, and their lung function and the scarring of the lung, what we call interstitial lung disease, slowly improving. Now, they're not who they were. They're still, I don't want to say permanent adverse effects, but they kind of are permanent. I mean, they've never really been who they were prior to that infection in terms of functioning, functional capacity and those kind of things. And even when we do their breathing test, their lung function is not normal. Now, after the Delta version, we obviously had much milder versions. And most of those people, did not need to be intubated. They needed to be in a hospital and they needed to be on oxygen, but they were able to survive. And yes, we do see long COVID syndrome, and it has different manifestation. It could be just fatigue. They're just tired for no good reason. Some of them could have neurological deficits. They're just foggy. They just cannot think right. They forget, they just don't remember things like they used to. Some of them is pulmonary. Just their breathing is just never the same. And you scan their lungs don't look terrible. You do their breathing tests don't look terrible, but they're short of breath. And you send them to the cardiologist to make sure that there's no cardiac component, and they pass with flying colors. So there is something subtle about this virus that I still don't think we have a good understanding of, in terms of how it affected every individual in such a subjective way. And everybody kind of had a different manifestation of it. So it's still it's still a challenge, because when you see those patients, you really don't have a whole lot of options for them. You throw them with some inhalers with the hopes that, that will help some of their symptoms. But short of that, really is kind of retraining them, how to breathe all over again.
Speaking of breathing, for folks who have sleep apnea,
yeah.
don't laugh, Dr. Kane. Look like I'm always talking about myself, doesn't it?
That's why I'm laughing.
For folks who have sleep apnea, why is it that so many people have sleep apnea?
Oh,
and
my goodness.
I've met some skinny people who have sleep apnea, so it's not always about being a heavy person.
Oh, you are 100. So, by the way, everything that you've asked me, I'm not kidding, is in that presentation. I'm not kidding. So, and it's funny because think about it. Sleep apnea is not really a pulmonary issue, but I added it to the presentation because of what you just said. Because not only am I an ICU doc and a lung doc, but I'm also a sleep doc. So I practice sleep medicine as well. So, and frankly, probably 25% of my practice is sleep. Okay. And I highlighted in the presentation exactly what you said. Most sleep apnea is related to our weight, but there's a good percentage of it that is related to our anatomy. Okay.
Yes.
And there's nothing you and I can do about it. Okay. It's just how God made our anatomy. And really what sleep apnea is when you and I go to sleep, our muscle tone relaxes, including the muscles that support your tongue, right? And so if you have a narrow, crowded mouth and you go to sleep, that tongue basically, specifically when you lay on your back, can just follow gravity and basically block the opening of your mouth. It becomes a plumbing issue, basically, where now that tongue is sort of kind of blocking the opening of your mouth, and you're having kind of that loud snoring that sometimes can turn into an apnea, which is stopping to breathe. It's a transient thing. It's only for a couple seconds, but if it happens consistently throughout the night, then it becomes a problem. If you look at I actually remember this statistic. Approximately over 930 million adults in the whole world have sleep apnea. Think about that. Wow. Think about that statistic. I still remember it. It's in the presentation, but it's there. So in my opinion, I'm not kidding. In my opinion, every adult should have a home sleep study. It's a very easy study. It's very cheap. It's covered by an insurance company, but it screens you for something that could cost you a whole lot more down the road. Sleep apnea is associated with every bad thing that you can think of: heart disease, strokes, rhythm problems, congestive heart failure. I mean, you name it, fatigue, inability to just function, to be yourself. So if you're having any sort of like subtle symptoms of it, if your spouse is telling you, oh, by the way, you snore real loudly and sometimes you scare me because you're looking like you're stopping to breathe. If you wake up in the mornings and you feel like, this is very unrefreshing, I didn't feel like I slept. If you're struggling throughout the day with lack of energy and getting a little sleepy throughout the day, I would go to Dr. Kane or somebody. It's such an easy test to do, and it will give you so much information that will make a world of difference in your life.
Listen, I tell people that I don't sleep without my CPAP machine because all of the things that you said, that was me. Yeah. But being written up on the job for sleeping on the job, that prompted it. But Dr. Kane was my primary care doctor at the time, and I just started asking questions.
Yeah.
Why is it, such and such and such? And then we did the dreaded sleep study.
Yeah.
And they said, well, if it, depend upon how it looks, we'll call you back. That's what the respiratory therapist said. And they called me the next day. I'm like, don't call me. But I tell you, I never sleep without my CPAP machine.
Yeah.
And I know the difference between a bad night's sleep and a good night's sleep. Yeah. And I tell people, but I've had people, Dr. Washira, who will not use that CPAP machine. And I'm like, okay, so do you understand the consequences of that?
Yeah.
Like you said, the heart disease and other situations that it could cause.
Right.
They don't. Let me just say this real quick. A couple of things I gotta say it. When it came down to COVID, and I've said this on the air before, but I had 4 patients in the same family to die within 48 hours
Oh,
of
wow.
each other.
Wow. Wow.
For the mother, the grandmother, the son, and another daughter
Oh,
to
wow.
die within 48 hours each other. Actually, 3 of them died within 24 hours each other,
Yeah.
as far as COVID is concerned. And the 4th one is the one that took a little longer.
Yeah.
And I mean, that's heartbreaking. And
Right.
3 of them were my patient,
Oh, wow.
and
Yeah.
we did, I mean, it just hit.
Yeah.
With
Yeah.
that being said, I just wanted to make sure people understood what the effects of what happened with COVID. And that, granted, we don't see it as bad as it was then,
Yeah. Yeah.
but we do see residual
Right.
anywhere from cardiac to pulmonary
Right.
to neurological residuals that
Right.
are happening with COVID that we're still trying to figure out.
Right. Right. Right.
The other thing is, Ms. Turner, is what you're saying in terms of sleep apnea. My thing has always been that I try to tell patients, when you're suffering from sleep apnea, your oxygen level to your brain drops way down.
Right.
And that can be like if I tie one of your legs off with a rubber band, a large rubber band, and I tell you to get into a race, that leg won't be useful
Right.
until I release that rubber band.
Right.
And so there's a lot of things in which we're talking about this evening that we're expecting in future conversations that Dr. Washira will get in more detail with and more in depth. And he has an excellent presentation. I know we're getting to the close, and so my summarization somewhat is this: we're expecting, we're hoping that he will come back. And now we get into detail of the COPD, which is like asthma, emphysema, that we get into the different things that can cause lung disease.
Yep.
And he did an excellent one. Anybody that want to go back, the fellow professionals, the fellow physicians, an excellent presentation in terms of a PowerPoint presentation for them to look at that we will post on our website that they can go and take a look at. But for the patients that are not very scientifically or very astute as far as medicine is concerned, and that's many people, most people, we don't expect them to be. That's why we in business to do what we do. They can go back and they can take a look at it, but the future program is going to be the most explanative, or the best ideas you can get from what Dr. Washira has to offer, and people like himself, those pulmonologists that can offer. Now, not everybody is a good pulmonologist, but I got one. And that's Dr. Washira.
I appreciate that.
Ms. Turner? Oh.
So, this has been a lot, Dr. Washira. I just am so amazed that all that I learned about lung health, because quite frankly, you brought up a lot of stuff that I didn't think about, but there are things that I know that people are experiencing on a regular basis.
Yeah.
And so we are at the end of the hour. Again, we need to invite you back, as Dr. Kane says, because there's so much depthness to this discussion. But we, at the end of the podcast, we do like to give our guests an opportunity to share their final thoughts. Can you share your final thoughts for our audience regarding lung health tonight?
Yeah. I think the biggest thing for me is just emphasizing that, to the audience and each individual that they matter, number one, right? Very simple message, but very important message is, specifically when you're dealing with your health, your perspective and what you're going through matters. And so it's incumbent upon you to voice what you are experiencing, specifically to your primary care doc. That's where Dr. King comes in, and his role is so vital because him and his partners, they're the quarterback of the team, right? And depending on whatever issue the patient is dealing with, then Dr. Kane and his colleagues are able to refer out, kind of the whole analogy of, the quarterback knows where the ball is going to go. Sometimes it needs to go to the tight end. Sometimes it needs to go to the wide receiver. Sometimes he needs to hand it to the running back. Sometimes he needs to tuck it in and run it himself. And so he will guide you on where to go in terms of whatever concern that you're having. If it's sleep issue, he will send you to a sleep doc. If it's a heart issue, he's going to send you to a cardiologist. If it's a pulmonary issue, he's going to send you to a pulmonologist. So just being empowered that you matter, that your health matters, that if you feel like you're not getting sufficient care, satisfactory care, then there's nothing wrong with getting a second opinion or even a third opinion. I never get offended when my patient says, you know what, I'm going to go, see this other lung doc. And I'm like, you know what, by all means, it doesn't affect my ego, because I want to make sure that I'm leading my patient in the right direction, because like I said before, sometimes we miss it. Right. So just emphasizing to the audience that, empowering them that their health matters, that their perspective matters, and they need to be in an environment where they are valued because they bring value. And sometimes it might mean sticking with the same doc that you're with, and sometimes you might need to jump ship and go somewhere else. And there's nothing wrong with that, because you and I have this one life to live, and we got to make sure that we live it to the best of our ability. Because as much as I need the best version of you, the best way you need the best version of me. And we cannot be that without our health. So thank you again for inviting me.
Wow.
Much
Wonderful.
appreciated. Yeah.
That was wonderful. I love that summarization. Thank you. And don't go anywhere. I don't know if Dr. Kane told you, we'd like you to hang on just a couple of minutes after we log off. Dr. Kane, what are your final thoughts regarding tonight's topic?
I concur with Dr. Rashir complicitly in that that's one of the reasons I send you to him. We have a similar philosophy. I love being wrong when it has dire consequences.
Yeah.
I would love to be wrong.
Yeah.
And you come back and say, Dr. Kane, I'm absolutely fine.
Yeah.
Because that's good for my patient.
Right.
It's good for the individual. Actually, it's good for me because I'm not the death sentence on anything.
Yeah, right.
And so I love it when I hear physicians of same philosophy that are not of higher than God,
right.
next to God, in terms of what their philosophy is.
Yeah.
So I really appreciate Dr. Washira. And I think some of the patients that are listening to us can understand why I send you there. I know they most definitely appreciate it at this point, because he came on and he's talked about what it means in terms of lung health. In addition, he has an excellent PowerPoint presentation where we will post to our website. Most of it is going to be understood by physicians, especially primary care physicians. But patients may understand some of it as well. The bottom line is, get to see your doctor, your primary care, especially whether it's me or anybody else. I don't care. Just get to see someone. Mm-hmm. As far as your lung health is concerned, and hopefully they will send you to someone who really gives a damn about your lung health. Mm-hmm. Because that's the other part of the problem, is that some people just check the boxes and are not really talking to you as the individual, as the patient. You're the patient. And even though you're the patient, you're still my employer. Yeah. And that's the way I look at it. If you're my employer, I'm going to do what my employer wants me to do, as long as it is truthful, honest, and providing the right information to help you make the right decisions as far as it is concerned my employment, i.e. meaning your health. So I appreciate you, Dr. Washira. We're on the same plane. I will continue to utilize your services. Yes, hopefully you won't get bored with them. Hopefully you won't. Hopefully I won't overwhelm you. But your wit and wisdom is great as far as our community is concerned, and we really need more physicians out there, whether they're pulmonologists, cardiologists, which we got a few, nephrologists, which we got a few, or primary care physicians, we got a lot of few. And hopefully they're all listening and hear what we are trying to do for our community. Ms. Turner?
Thank you again, Dr. Rashira. And thank you for joining us for today's important discussion on African Americans and lung health. We uncovered the challenges impacting lung health in the Black community, such as environmental injustices, systemic barriers, and health disparities, and explored actionable steps like early screenings, quitting smoking, and of course, advocating for cleaner air. And let's keep the momentum going. Contact the American Lung Association, reach out to Dr. Washira, and we'll make sure that we include his information if you need a good lung doctor to access lung health resources or to have a valuable expert such as Dr. Washira. Find local screenings and learn how you can advocate for change in your community. And of course, share this podcast with someone who could benefit from it. And follow us, as Tyrone put across the screen. Follow us on YouTube. Subscribe to our YouTube channel week by week. And by the way, we do this every week. We try to bring topics to you that we think would benefit you and your families. If you have any ideas regarding future topics in 2025, send us a message at info@pauseforthetruth.com. And again, we'll share Dr. Washira's contact information because, as you can see, he's a great doctor. I just met him tonight, but learned so much from him. Thank you for tuning in to Pause for the Truth. And I don't believe we're going to have an episode next week because you're probably going to be getting ready for Christmas because it'll be Christmas Eve. So we're going to probably rebroadcast an older episode, maybe this one, because I think this is a real good one. And, look for us in a couple of weeks as we start back with a new podcast. Thank you again, Dr. Rashira, for coming on. Merry Christmas, happy holidays, drink responsibly, eat wisely, exercise, take a walk with your family after you eat that high carb meal, because I know about all the potatoes, the macaroni and cheese, the cornbread, and all the delicious desserts that we're all enjoying throughout the holiday season. And thank you again for tuning in to Pause for the Truth. Good evening.
Now you see why you need to tune in every Tuesday at 6:30 p.m. Eastern Standard Time. It's been an absolute joy having you with us today on Pause for the Truth. Dr. Rogers Kane and Ms. Jocelyn Turner are so grateful for your time and support. We know you have a lot of choices, and we're thrilled you chose to spend your time with us. It means the world to us. A shout out to Tyrone Jackson of Call Tyrone IT Services for making everything run smoothly behind the scenes. Tyrone, you're truly a whiz. Remember, folks, we're here every Tuesday at 6:30 p.m. Eastern Standard Time with more insights, stories, and truths. So mark your calendars, set those reminders, and join us for another exciting episode. Thank you once again. And we can't wait to connect with you next week. Stay curious, stay engaged, and most importantly, stay tuned. Don't forget to like us on Facebook, link with us on LinkedIn, and most of all, subscribe to us on YouTube. Never forget to pause for the truth. Thanks for your support. Have a great